from Dr. Ranusi, which she is supposed to have. My name is Dr. Al-Hassan Datu Mohammed. I'm the chair of the Nigerian Society of Anesthetists. Our 9th webinar series, session number 6. And we'll have a very important speaker who we were lucky to catch somehow to share her experience with us. Traditionally, we're supposed to start when we have 50 participants or when it's 5 minutes after 5, because we don't want to waste much time. So we have our moderator in the person of Dr. Abiola Adejumo, who is a consultant anesthetist with the University of Abuja Teaching Hospital, Gwagwalada, Federal Capital Territory, Abuja. She will guide us through this presentation and read out all the other instruction guiding this webinar. So Dr. Adejumo Abiola, over to you. Thank you.
Okay, thank you very much, Prof. Good day, our highly distinguished trainers. Our speaker for today, Dr. Peace, all physician anesthetist, nurse anesthetist, anesthetic technician, and every other distinguished ladies and gentlemen present for this webinar today. Once again, my name is Dr. Abiola Adejumo, and I'll be moderating this 6th session of the 9th webinar series, which has been organized by the Nigerian Society Anesthetists. Read some few rules that are guiding this advice to stay muted. And if we have any comment and answer session, if we have any questions, we'll do well to raise up our hands, after which we'll be called upon to make our comments and questions. Without wasting much time, permit me to introduce our speaker for today, the person of Dr. Peace Ene. She's an assistant professor of anesthesiology and consultant in the Division of Pediatrics Anesthesia at the Mayo Clinic, Rochester, Minnesota, United States of America. Dr. Ene chose a career in medicine with the aim of empowering the unwell, providing them with a chance to regain health and pursue their aspirations. Her devotion to clinical care and education are guided by the philosophy that a healthy man has many dreams, but a sick man has only one dream. Driven by the belief that quality healthcare is a fundamental right for all, she advocates for the idea that everyone deserves the opportunity to dream, be ambitious, and live life to its fullest potential. Dedicated to expanding access to safe anesthesia care in the low-resource environment, Dr. Ene focuses on building robust educational system for the local healthcare providers. She actively engages in bidirectional educational opportunities between the high and the low-resource countries, having collaborated in Nigeria, Bangladesh, United Arab Emirates, Zambia, and Ghana, with a commitment to forming more global partnerships. At Mayo Clinic, Dr. Ene played a pivotal role in initiating a global health elective for anesthesia residents. This program involves Mayo Clinic faculty and trainees spending a month in Zambia, sharing their experiences in anesthesia education. Prior to the Zambia experience, she actively contributed to developing an educational curriculum for both visiting faculty and residents, establishing a solid foundation for collaborative resource sharing and knowledge exchange. Her current research concentrates on 3 key areas, which are investigating the role of medical education in mitigating the impact of brain drain through locally cultivated programs and collaborative practices. 2, creating objective metrics to evaluate the impact of global health education initiative. And 3, enhancing sustainability by identifying crucial components of successful interventions and applying this knowledge to shape future projects. Dr. Ene is excited for future collaboration in this field. Distinguished ladies and gentlemen, at this point, join me as we make welcome to be leading us in a presentation with the topic Management of Pediatric Difficult Airway. And we welcome Dr. Peace Ene as she takes us through this presentation. Dr. Peace Ene, you're very much welcome. You have 45 minutes for this presentation, after which we take questions and comments, clarifications. You may have the floor, ma. Thank you.
Thank you so much for the wonderful introduction. To say that this is a dream come true is an understatement because it perfectly aligned with my goals. When I left Nigeria many years ago, it was with the intention of eventually finding a way to collaborate and work with my colleagues in Nigeria to improve access to anesthesia care and make it more sustainable. So I am very grateful for the opportunity to be speaking with you all today. And I also want to extend a special thank you to Dr. Bisola Briggs, who I encountered at the World Congress of Anesthesiologists in Singapore earlier this year. And this is where this connection has grown and expanded. And I'm very thankful for the invitation to share with you all this evening. So I will go ahead and share my screen here. Is that visible to everybody?
Yes.
Okay,
yes.
Great.
Yes.
Great, awesome, great. All right, so again, I'm an assistant professor of anesthesia and I practice in the division of pediatric anesthesia at the Mayo Clinic in Rochester. And I'd like to extend another gratitude to Dr. Devna Ganga, who's also Nigerian. But we see him as the pediatric airway expert in our facility here because he is very interested in this topic. So I appreciate his mentorship on this topic. And so I'll go ahead and get started. So just making sure my slide advances here. All right, so the objectives of my talk today will focus on predicting pediatric airway, difficult airway, because I believe that if we're able to predict this, then we can do something about it. So the first objective that I will be addressing today will be about the features that we see that can help us identify a patient that potentially have a difficult airway. And then the second objective will be to discuss the management of both anticipated and unanticipated difficult airway. And then finally, we'll talk about some of the techniques that we can use, some that are very familiar with you all. And we'll talk a little bit about some of the advanced techniques for managing difficult airway. And I will say, I will ask and please be as engaged as possible with this talk. If there are any questions, please feel free to either enter them in the chat box so that we can collect those, or you can raise your hand and ask any questions for clarifications. And along with the presentation, I will have some questions also for the audience. And so I will really encourage you to please participate in answering the questions or in giving me some answers. I'm going to be doing a poll at some point just to have a better understanding of who is present and to make sure that the talk is directed to the right audience. I don't want to talk about things that will not really be useful in your practice. Thank you. All right, so we're gonna go ahead and talk about the first, which is talking about the features that are associated with pediatric difficult airway. And so why do we care about this topic? Why is this important? As you can see from these pictures, again, these are things that are unique to pediatric patients having a difficult or challenging airway. And in the 1970s, 1980s, this used to be a bigger challenge. About 50% of all perioperative cardiac arrests were due to respiratory causes. And when you have a situation where you're not able to secure a patient's airway and they develop hypoxemia, They can also, as you all know, develop bradycardia and eventually cardiac arrest and even death. And so this is not a small fit. It's a very big deal for us anesthesiologists in our management of patients. And thankfully, this number is going down, down to 25%, which is still a lot of cases. And, the decrease in the incidence of this cardiac arrest, is due to, now we have better monitors, or we have monitors for detecting, hypoxia earlier on. We have better equipment for intubating our patients or managing their airway. We have better medications that can be more easily reversed in the event of a difficult airway. And we have better training. Obviously, the more trained, the more experience that we have with managing a pediatric difficult airway, the better the outcome. And data supports that in situations where you have a more experienced pediatric anesthesiologist, of having adverse events is much less. But, again, if we still look at the data showing that 28% of anesthesia-related mortality is due to difficult intubation or ventilation. So again, still a very big issue in our practice. And I tried to look for data, specific to Nigeria to see if we have any data about pediatric difficult airway. But unfortunately, my search did not turn up a lot of results. And so kind of taking a closer look, okay, if we can find data specific to Nigeria, maybe the data exists, but I'm just not aware of it. So if anyone on here has any data that they're willing to share on this, please feel free to reach out to me. But the data that I was able to find, somewhere that's closer to home was in Addis Ababa in Ethiopia. So they did a multi-centered study, and they involving about 5 different hospitals, referral hospitals. And for this study, they included, or they looked at patients, pediatric patients, and from 0 to 5 years of age. They were undergoing elective procedures, so not emergency cases. These were scheduled cases, and that required endotracheal intubation. And they also selected patients that were ASA 1 and 2, so relatively healthy patients coming in for elective procedures. And they excluded patients that had their endotracheal tube placed using an indirect technique, so maybe using a video, or a laryngoscope, or a fiber optic, or any advanced technique. And they also excluded any intubation that was done by students. And so what they were, their results showed that they had out of the, so they selected, again, they didn't include all the patients that were in that time period. They selected 290 pediatric cases, and then, had they collected data on how the intubation went. So they defined difficult airway as if the patient had a difficult mask ventilation, or if they had a difficult laryngoscopy, or if they had a difficult tracheal intubation. So any combination of these, or in presence of any of this, will characterize as difficult airway. And their rates, so they found that out of the 290 pediatric cases that they looked at, about 19.7%, so almost 20% of those had one of these, so difficult airways. So this number is very high compared to other numbers out there, especially in the, kind of comparing between Ethiopia and other, more developed countries. And you can see like the numbers that they got for specifically for difficult laryngoscopy, difficult mask ventilation, and difficult intubation. And so I think for me, the more important point from this presentation or from this paper is like the factors that were associated with the difficult airways. So patients that were less than 2 years of age were more likely to have difficult intubation, difficult airway, and then patients that were on the way, so low weight patients, and patients that already had difficult history of difficult airway, or patients that were anticipated to be difficult were likely. And then also, again, the point about the experience of the anesthetist. Patients that were taken care of by anesthetists that had less than 4 years of practice were more likely to have a difficult airway experience. But again, every study, no matter how good it is, will always have limitations. And so one of the limitations of this study, it cannot really be applied broadly to all patients, because again, in their selection of patients, they selected relatively healthy patients. So again, in a larger tertiary institution where you're doing more difficult cases, patients that are ASA 3 or 4, we know that those patients also tend to have a more difficult airway. So I would anticipate that if they expanded their patient pool, that they will have a higher rates of difficult airway. And so let's just define what a difficult airway really is. So again, it's in a situation where a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway if they have any difficulty with tracheal intubation or both. So it's in line with the definition that the group from Addis Ababa used. And so what do we know about difficult airway in children? So we know that difficult intubation is rare in children overall when compared to adults. So the data that we have here from a study that was done in Philadelphia, Children's Hospital of Philadelphia, when they looked at their large sample size over 5 years, they found that the incidence of difficult intubation was about 0.25% for all kids. And a different study looking specifically at cardiac, children coming for cardiac cases, who again, if they have any cardiac disease, they tend to be in that higher ASA status. They had a higher incidence of difficult intubation at 1.25%. And then again, even though this is rare in children, the thing that to note is that there are complications, and those complications, abound. So again, looking at this pediatric difficult airway registry, looking at 13 different hospitals, they had a case of over 1,000 difficult intubations between a 3-year period. And so if you look at the table, you can see that even though they were able to successfully intubate 98% of the children that were identified as having difficult airway, 2% of them still had a surgical or failed airway. So again, it's a pretty significant number. And again, those 20% of those had some complications, so any complication, and then the severe complications was 3%. And those complications were associated with if you had like more than two tracheal intubation attempts. And then again, you can see that weight less than 10 kilograms. So low birth weight children have like a higher risk for having complication. And then also children that had a short thyromental distance or had more than 3 direct laryngoscopy attempts also tend to have more complications. And the complications we're talking about here, again, the very severe one, the cardiac arrest that we already spoke about. And then we also have the severe airway trauma, death even, as a severe complication. And for the non-severe ones, we have, temporary hypoxemia, so minor airway trauma, laryngospasm, bronchospasm, and the rest. And so again, just another point, what else do we know about difficult airway in pediatrics? We know that most difficult airway in children are often predictable. So again, this is the good news. If we can predict it, then we can do something about it. And so in adult population, we have these mnemonics that we use to assess for how difficult or easy their laryngoscopy or masking would be. But unfortunately, these mnemonics are always not, you can't really apply them to children because, again, if you look, obesity, no teeth, having beard, those things are not applicable to children. And what they don't have here is the children that have syndromes and and etc. So again, they're not really applicable, or they don't translate to the children. So we have to have a better way to predict difficult airway in children. So here's my first question session. So I will open the chat here to see if I can get any response. So which of these are the 2 most common physical exams that will indicate a difficult laryngoscopy in pediatric patients? So you can just put A, B, C, or D in the chat. If you can see, I can read it out just in case anyone cannot see. So cleft lip on cleft palate, large occiput, also a large head and relatively large tongue, narrow interincisor distance and mandibular hypoplasia, large tonsils, and suspicious diagnosis of obstructive sleep apnea. All right, I have just one response so far. All right, so just to kind of stay on time here, the answer will be C. So having a narrow incisor distal, which means really small mouth opening, or mandibular hypoplasia, those are the two most common physical exams findings that would indicate difficult laryngoscopy. All right, so again, going back to predicting. So again, so one thing that I do whenever I have any child coming in, goes to review and see if they've had any anesthetic in the past. I'm sure many of us do that because again, that gives you very valuable information about what to expect. So if a child has had any history of difficult airway, then you should definitely anticipate that they might be difficult and you should prepare appropriately. And then the next would be the look test. So what is the look test? This is where we are looking and basing our information gathering based on their physical exam. So, coming in the room and then you look at the child. Again, that's why as an anesthetist, we obviously, will go and see the patient before surgery because we can gather a lot of information about the patient, about the airway by looking at the child. So what we're doing when we're looking is we're really assessing the space available for laryngoscopy and also looking at if there's anything that will make mass ventilation difficult. And so we're looking at the mandible, right? So like we're looking at the upper jaw, we're looking at the lower jaw and seeing the relationship between the two. And then we're also trying to see like how easy it will be to open. Even when we tell the children to open their mouth, we're trying to see like how the mouth, how they open relative to one another. We also want to look at their cervical spine and how they, how their neck mobility is, because that can also, so if you have like a child with a syndrome where like their neck is pretty much fused, you can anticipate that that will be very challenging to do laryngoscopy because you cannot manipulate the neck very well. And then you're looking at the size of the tongue and looking at the nose and seeing if there are any other facial features. Obviously, if they have a large tumor, if they have any radiation effect, any mass over the front of the neck, if they have any burns, all of those. Physical exam is very, very important in this case because that can give you a lot of information about what to expect. And then, so specifically, as we talked about in the question and answer, so again, micronadia is a term that we tend to use when we talk about difficult airway in children. So it really means mandibular hypoplasia or a small jaw. So when you look at the child and their jaw looks like it's recessed, so it's back, it's further back than the mandible, than the maxilla, then that will be a big strong clue that they might be difficult to intubate. Again, narrow incisor distance, again, is a very small mouth opening, and so that also will be a challenge. If they have an extremely anterior airway, I apologize for the overhead announcement. Or if they have any other syndromes.
Medical alert, code blue, NASA tower, 6A is an alpha from 850. Attention, medical alert, code blue.
I apologize for that. So again, so syndromes associated with, if they have any syndromes, and we'll get to these syndromes, that can be associated with a difficult airway. So those are the things that you're looking for more specifically that can tell you that a patient might have a difficult intubation, difficult airway. And so based on your exam, it's really important to decide, would this child be difficult to ventilate, so to do a mass ventilation, or would they be difficult to intubate, or will it be both? And so some of the things that can help you decide if it will be a difficult ventilation versus difficult intubation. So mid-face hypoplasia. So if the middle of their face is sunken in, or they have had any ENT surgery that's kind of obstructing your airway, they have large tumors, they have had radiation or burns. So again, this might make it difficult to do mass ventilation. And then for the difficult intubation, again, we talked about the mandibular hypoplasia. If they've had cleft palate, that tends to make it more difficult to intubate. And then, something that a large tongue can make it both difficult to ventilate the patient, and then also difficult to intubate. If they're small children, if they have those syndromes, obesity and obstruction obstructive sleep apnea can actually cause difficulty with both. And so just briefly reviewing the syndromes, I don't want to spend too much time on the syndromes because the prevalence of these syndromes kind of varies based on where you're located in the world. And so the ones that we know here, and I will be very eager to hear from the comments if there, please feel free to leave anything in the chat. If there are any other syndromes that you can identify that's more prevalent in Nigeria that you've seen that has been associated with a difficult airway. But for us here, so we have the Crouzon syndrome. And again, if you look at all these children, you see that the middle of the face is a little sunken in. And so that will really make it hard to use a mask over the face. And then the syndromes with mandibular hypoplasia, the Pierre-Rubin sequence is one that we are very familiar with here. We see it a lot. And if you look at the picture, you can see like how far back the mandible is in relative to the maxilla. And then, these two other syndromes also come with that. So whenever you see children having those features, you should anticipate that they might be difficult to intubate. And then with macroglossia, which means large tongue, patients with trisomy 21, again, or they have the Beckwith-Wiedemann syndrome or the Hurler-Hunter syndromes, they, again, will be difficult to mask and also relatively difficult to intubate. All right, I'm going to skip on this just to keep on time, but the answer for this, again, we know that kids with Down syndrome tend to have the atlantoaxial subluxation. They have the heart defects, the ASDs, and they can be difficult to mask ventilate, and they also tend to have obstructive sleep apnea. So the incorrect answer here is the micronatia. So the Down syndrome kids don't have micronatia. And I just wanted to put this website out here because it's one that we commonly refer to. It's called the orphananesthesia.eu. So they tend to have a lot of information about these rare syndromes, so that if you type in the name of the syndrome, they will tell you the anesthetic implication for them. So, if they've been reported to have difficult airway, then this will highlight that and it will make some recommendations. So this is something that we use quite commonly, so I recommend being familiar with it. All right, so what do we do about the difficult pediatric airway? So I will just focus on these principles because I feel like if at any point we are, thinking of this, have this at the back of our minds when we're taking care of pediatric patients, then that will go a long way in helping us be prepared. So whenever we're doing like intubating patients or trying to manage their airway, I always opt for maintaining spontaneous ventilation as much as possible. In the initial stage until the airway is secure, at least you know what you're dealing with. So again, this will allow them again to continue to breathe, to continue to oxygenate, and then you're now figuring out if you can actually mass ventilate the patient. Because again, if at any point, if you're able to maintain spontaneous ventilation and they're able to breathe on their own, then you're not in a difficult spot yet. You can still change your plan, do something. So I always, and when we have the sevoflurane, and the good thing when we give pediatric patients sevoflurane, a lot of the times they can still maintain their mask ventilation, and then you can evaluate and see how is my masking going, can I get a blade in and things like that. But again, they're still breathing on their own and they still maintain it, so you're not in a bad situation yet. And then, if possible, always provide continuous oxygen therapy, whether it be through a nasal cannula or any other device that I will talk about later. Even if you're managing a difficult airway, if you can still provide some oxygen therapy while you're doing that, again, this will give them time, this will buy you time so that you can do whatever it is that you need to do before they start crashing. Remember, we talked about that. It's the hypoxia that can lead to bradycardia and eventual cardiac arrest. So if you're able to provide continuous oxygen supply at all times, this is really important. Again, positioning is important in these kids. Again, knowing that they have like a large occiput, like a large head, and using like a shoulder roll or optimizing your position, whatever you need to do can help. And then I think the most important is having an exit plan. And I say plans because again, it's important for us as anesthesiologists, to think and have option A, B, C, D, if things are not going well. This is what our specialty prides ourselves in always being prepared. So and then also knowing that again, if things are not going well, you can always abort and revisit if you haven't gotten to the, the more difficult algorithm. So, okay, so for, if you have a patient that you've, have come in and you anticipate that they will have difficult airway just based on the exams that you've done and, looking at their prior history or, from, then you have time. What this means, you have time to do things, right? You have time to gather your supplies. You have time for your team to consult with ENT. You have all the teams that you have available. You have time to optimize the patient in whatever way, maybe they need to be fluid resuscitated or, better pain management, whatever you need to do to make sure that the patient is in a better place. You have time to obtain a peripheral IV, which can sometimes be, life-saving in these cases. And you also have time to decide if you need to move forward with the case or not. However, when you, just kind of walking through this, this chart that I found on this paper. So again, when you're managing a pediatric difficult airway, and especially if you're not in a tertiary setting, I think the most important thing is, again, to assess how well and if you should really continue with this case. And so if you're you don't have any prior history of a difficult airway and your assessment of their airway is abnormal, again, you decide not to attempt the sedation or anesthesia and refer them to a higher level of care. So if you can refer them where they're more comfortable managing the difficult airway, that would be better. Or even if your assessment was normal and then you now enter a way, your assessment was normal, but then when you try to intubate and then you get into a challenge, again, you can always, if you can easily mass ventilate the patient, then you should wake them up and then refer them to a higher center. Because again, it's when you get to the point of no return, then that becomes really challenging and patients can have suffer morbidity or mortality from it. And then always remember to call for help. It's always easier and better if you have extra help to help you gather your equipment and prepare and mask the patient. And so when you now have the unanticipated difficult airway, obviously you don't have time for all the things that we talked about. And so that means you've entered like an emergency pathway. And so what your option at that point is to rescue the patient however you can. So it can be, again, to optimize your mask ventilation using a nasopharyngeal airway or oropharyngeal airway. If you have like an LMA or supraglottic airway, that's what you will go to for your next plan to rescue the patient. And then also, prepare for possible surgical airway. And so again, just walking through this, I think these are important things to keep in mind for difficult mask ventilation. Again, you see here, administer 100% oxygen all the time, as much as you can to buy you time. And then again, call for help. And then at every point, you're using like oral airway, optimizing your position, make sure that you can mask the patient. And then if there's any airway obstruction, figuring out, is it a laryngospasm, bronchospasm, doing an oral airway, nasal airway. So again, optimizing, and then at any time, you can always, abort if you can. And then if you have a failed endotracheal intubation, again, administer oxygen, call for help, again, because the sooner you can get help, the better. And if you have easy masked ventilation, then you're not in an emergency pathway yet, because again, once you can mask the patient, you have time to try different things. So you can repeat your laryngoscopy, you can change your position, change your blade, use more advanced techniques like the indirect laryngoscopy, the fiber optic intubating LMA, or again, if you can't mask the patient, placing an LMA is like your next go to, and then again, calling for help. And then finally, if you're in a place where you cannot intubate and you cannot ventilate, then it's calling for help, ENT, emergency airway. If you have a surgeon available, they can do a rigid bronchoscopy. If the patient is not, if the surgeon is there, then you might need to do a needle cricothyrotomy. I will get to this more detail, but again, it's just being familiar. Again, I feel like the most important thing is recognizing what is going on so that you can take the appropriate action. So again, calling for help, having oxygen available so that you can rescue the patient. All right, so again, for this question here, if tracheal intubation is difficult after induction of general anesthesia, the most critical factor in electing to continue attempts at oral intubation is, so option A, availability of a trained assistant. Option B, history of successful intubation. Option C, ability to visualize the epiglottis. Option D, ability to provide satisfactory mask ventilation. And option E, low aspiration rate. So which of these would tell you that you can continue attempting oral intubation? All right, I have a few responses here. I just need a few more. Yeah, that's correct. D is correct. So ability to provide satisfactory mask ventilation, that's the most critical point. So again, if you can mask the patient, right, then you can continue, change things up, maybe a different intubating equipment, but if you can still mask the patient, then you can continue to try. But again, I would say, even though you can continue to try, again, remember the first slides that we looked at, the more attempts you have, the higher the chances of complication for the patient. So again, you have to be careful while trying. All right, so I'm not gonna talk about some of the equipment and the techniques. All right, so again, another audience response here. If you can please just type out, what do you have available where you practice in terms of devices that you use to manage the airway? So we have the options are, if you have a bougie, if you have the supraglottic airway, also known as the LMA, obviously, most of us will have the direct laryngoscopies. Well, do you have the video laryngoscopes, like the glide scope or the CMAX, or the different types of video laryngoscopes? Do you have fiber optic bronchoscope? Do you have the availability of the rigid bronchoscopes? Like the ENT team will have the rigid bronchoscopes, but you have the ability to do surgical airway, like a tracheostomy. So which ones do you have available where you practice? All right, so I've gotten some responses here. So it sounds like most likely have 1 to 4. So they have the bougie, the supraglottic airway, devices, the DL, and then the video laryngoscopes. And then some say they don't have the rigid bronchoscopes. Okay, and it seems like the fiber optic is not available. Okay, all right. Thank you so much for your responses. All right, so did I miss any of the, the popular airway devices? Anyone that you use that I did not have in the options? All right, so here I've kind of put in like what I think is an exhaustive list, maybe not, of the different tools that we have available for managing a pediatric airway. Again, so we have the face mask. Again, we can't not think about the face mask and the oropharyngeal airway and the nasopharyngeal airways. We have the nasal cannula. Again, if we're trying to maintain continuous oxygen supply, we need the nasal cannula sometimes, and the oxygen supply. When they have the bougies, then the LMA, DL, video laryngoscopes, fiber optic, the rigid bronchoscopes. Again, the rigid bronchoscopes, the ENT surgeons usually, that's what they use for their airway management, and can be a rescue technique. And then the surgical airway, and then of course we cannot forget the monitors, right? being able to see, have like capnography is also very important to make sure, if there's question about if the endotracheal tube is in the airway, the capnography can help us with that. So monitors are also very important. All right, so again, I just want to highlight a point here, because a lot of times when we're talking about, difficult airway, we always think about, okay, intubation is the key, right? But again, I would say in terms of thinking about morbidity and mortality, it's being able to ventilate the patient. That is what really saves lives. So we have to really think about what can I do to optimize my ventilation of a patient. Because again, if you can ventilate a patient, if you can mass ventilate them, then you have time to do different techniques and different things to secure the airway. So again, going back to ventilation, again, we need to have the appropriate size mask. Again, you might need a bigger mask. Say they have like a tumor in their face that's obstructing the view, or they have a large tongue. You need to make sure you have the correct size mask to be able to deliver adequate ventilation. Again, we talk about the nasopharyngeal airway or the oropharyngeal airway, making sure that it's the right size for the patient. And then we'll move over to the supraglottic airway. Again, this is a very, very important tool. I feel like sometimes we don't really emphasize how useful this tool can be, or some of us might not use it as often as possible to really know how to place them. But again, they can be a very important rescue device. So again, and when I was in Zambia, we had a lot of supraglottic airway devices available, which was great, because again, we sometimes can use it as just a standalone airway device, to ventilate the patient during a case. But then also to think that, again, it can be a rescue device, and it can also be a conduit for intubation. So if you have a well-placed LMA, then you can use that if it's the right kind, and you have a tube that can fit through it, then you can use it for intubation as well. And then I'm just showing here different types of the LMA. Again, again, like I talked about, you can use it to provide mass ventilation, or if you have a failed intubation, you can use it as a rescue device. Again, we have to just be cognizant that when the children are younger, it's so easy to misplace or to have the tube not fit. So it's really important to make sure that it's well positioned. And you have to note that, again, that if you're trying to use it as a rescue device, you have to make sure that the breathing tube, the endotracheal tube, can fit through the hole. So you have to make sure that it's the right size. And then also note that if you have cuffed tubes, again, the slits that the LMA have might not let you pass a tube that's cuffed. So you might have to use an uncuffed tube in that situation. And then again, there are some, again, sometimes people worry about aspiration. And so there are some newer or different LMAs that have like a GI tract, like one that you can pass like a suction through that will go into the esophagus, as opposed to, having things reflux. And then also we can use this for fiber optic intubation, especially the AirQ one. Our favorite here is the AirQ. Which is the one, and I'll show you later on how we can use that for fiber optic intubation. Again, just the different LMAs, and kind of noting like, again, this is why it's important to prepare, because what we do is, if we decide that this patient and this LMA might fit, then we'll see the endotracheal tube that will fit in through the LMA before we even start to make sure. So it's really nice to practice and rehearse, just to make sure that you have all the equipment together, and see, if you need to, make any changes to your selection of the equipment. And again, just kind of talking about here, if you can look closer at this picture, you see that there is this aperture bars. Again, if you place this and you want to pass a breathing tube through it, then you can see that you will encounter challenges with that. So if this is the only one that you have, you can cut this slit, right? And so that you can easily pass your breathing tube through it. And you can see in the picture that the tube can go through it. And then the picture on the right is the AirQ one. So the AirQ doesn't have those slits, so you can more easily pass even cupped tubes through the LMA. So again, if the LMA is well positioned, and you're trying to intubate, again, making sure that the this lets you know that you too can pass through it, and that it's not going to encounter, and it is well positioned. You really should go through the cord. Again, when we talk about direct laryngoscopes, again, people always ask, which one should you use, or which one? I would say, again, depending on what we understand about the pediatric airway anatomy, again, knowing that the epiglottis is very omega shaped and it's floppy, most of us tend to use like the straight blades. So the Miller or the Phillips, or, depending on what you have available. But again, Max can also be used if that's what you're most comfortable with. You just need to know that it's going to be a little different from intubating an adult with their Macintosh. So again, it depends on what you're most familiar with or most comfortable with, and then also depends on what you understand about the airway anatomy. And then again, when you try the first time and you encounter challenges, kind of pay attention to that, because that can influence you on if you should switch your blades to a different one, to a different size, and help you minimize how many times you're in the airway attempting. And then the video laryngoscope, really, this is the newest, not the newest, but I feel like most of us are moving towards using the video laryngoscopes in our pediatric patients that we think will be difficult to intubate, because being able to visualize the cords, especially if their airway is very anterior, has been found to be very helpful. And things to know with the video laryngoscope, just because if you're using, we have these straight blade video laryngoscopes and we have the curve like the Macintosh ones. So again, being cognizant of which one you have available. So if you're using the very curved video laryngoscope, you have to curve your breathing tube to match the shape and the curve of the video laryngoscope. That's how you optimize your chances of success the way that you normally. And I'm gonna kind of skip through the slides, because again, the main points here is that you have to really practice using them even in how it works, and then be able to use it in those difficult situations. I just want to put this out here because, again, it's referring to the data that I presented initially from Philadelphia, from the PD registry. So when patients, what their study was showing is that in patients that have been identified to have potentially difficult airway, the first attempts that the people did was the direct laryngoscopes, right? So used for first attempt, 46% used the direct laryngoscope, but you can see that the first attempt success rate was 3% with the direct laryngoscope. So again, but then for the fiber optic or the glide scope, which used for first attempts, was lower rates, right? But then they had much higher first attempt success. And based on this study, the new guidelines, or the understanding that most of us that practice pediatric anesthesia here moving towards, is to use the video laryngoscope as the first attempt for a patient that we have a suspicion that they have difficult airway. And the reasons are, again, the more you can minimize airway manipulation and airway swelling, the better. And we know, again, from this data that the first attempt success rate with the video laryngoscope or the fiber optic is much higher than doing the direct laryngoscope. So again, I would encourage you, if you have the video laryngoscope at your institution, to one, make sure that it's a small enough size for your patient, because again, the adult ones might not fit. We have the ones for the pediatric patients now, and if you do have it, that should really be your first attempt at intubating a patient that you think might have a difficult airway. And then again, I put this slide here just to show you that even patients that, it's the same data, but in patients that even are smaller than 10 kilograms, your chances of success with the video laryngoscope is much higher. And then kind of moving to the advanced techniques. So I know my time is almost up here. I think I have probably 2 minutes or so. So again, some things that I want to highlight again, a lot of times we might think, oh, fiber optic is the way to go. I mean, it's really is the gold standard, but there are ways that we can optimize our patients so that they have a better chance of success with intubation. And again, like I talked about, some of the things that we can do is to put a nasal cannula through the nose and connect it to the circuit. So if you take like the connector for your breathing tube and connect it to, even you can cut a breathing tube short, or you can use a nasal cannula. If you can connect it to your circuit, this way you can still provide oxygenation to your patient while you're trying to intubate. And also, you can do this for if you're doing a nasal intubation. You can still do this, use an oral airway and the right size oral airway and connect it to your circuit so that way, again, especially if you're still maintaining spontaneous ventilation, you can still use that to ventilate the patient while you're attempting to put the oral air while you're trying to put in the breathing tube. So again, these are some techniques that have been shown to be very helpful. And then finally, you can also use like, a nasal cannula, if you have nasal CPAP or the high flow nasal cannula, while you're trying to intubate the mouth, the trachea, through the mouth, you can still have something in their nose to provide oxygenation while you do that. The only caveat with those like the CPAP, high flow nasal cannula, obviously you're not going to be able to deliver anesthetic gas, but again, you can still provide oxygen. And again, briefly on fiber optic, I'm not going to dive into this, since the poll initially showed that maybe we don't have a lot of it. But again, it's another way, really the gold standard for managing patients with a difficult airway. And again, the invasive technique, again, I'm not going to dive too in, but again, it's something that we should always think about. And if we're encountering any difficulties, alerting our ENT colleagues early on and, being prepared can be very helpful for our patients. All right, I think I'm going to stop there and allow some questions. All right, so I will allow some questions here, and if we still have any time, and then I'll just kind of summarize afterwards, if there are any questions and discussions. Thank you.
Thank you very much, Dr. Peace. I want to use this opportunity to thank you and appreciate you for this beautiful presentation. It has been highly impactful, engaging, and we appreciate you very much once again. In summary, in the past 45 minutes, Dr. Peace has told us about the management of a pediatric difficult airway. And the main objective of this presentation were that, number one, we should be able to predict or identify the difficult airway. That means we should be able to identify the children that have potential difficult airways. And how do we do that? From history of previous difficulty. And we should also conduct the look tests, in which case we'll look at the mandible, we'll look at the maxilla for any form of sliding and hinge function of the jaw. We should also look at any form of C-spine range of movement and any form of C-spine abnormality. Also, we should take into cognizance the size of the tongue, as large tongue is there's high likelihood of having a difficult airway. And she also went ahead to tell us about some features that could be associated with difficult airways, such as micrognathia, a narrow interincisor gap, extreme narrowing of the interincisor gap, yes, extreme anterior airway, and some syndromes that could present as some various facial and jaw abnormalities, in which case we'll have difficulty. And the next objective was for us to be able to manage this difficult airway, the basic principles we needed to have to be able to manage these difficulties, which include that we should maintain spontaneous ventilation in the initial phase. So the main goal is at every point, let's ensure that we can deliver oxygen to these patients. Like she told us, hypoxia can cause bradycardia, which subsequently can lead to cardiac arrest. So we should maintain spontaneous ventilation, provide continuous oxygenation. We should optimize the positioning. The positioning of these patients is very, very important, as it will help us to be able to access the airway easily. Also, she told us that we should have an exit plan. Have a plan. If this does not work, what next? What am I to do next? So, and she told us that this difficulty could either be anticipated or unanticipated. In the case of anticipated difficulty, yes, we should be able to, that means we have time to prepare. You can get everything you need, get a good backup plan, get a support, all your supplies, all our supplies should be ready. We should invite, make it a multidisciplinary team, get the ENT surgeons, and everybody should be on ground. And she also gave us a scenario when we face unanticipated difficulty. And in that case, she told us it's an emergency airway and we need to rescue this patient. So basically in that situation, we have to optimize the ventilation, ensure this patient is taking in oxygen and bringing out carbon dioxide effectively. And in such situations, we're told that the LMA could come as a rescue and also use of the fiber optic bronchoscope. Then she gave us some tools that we would need for managing pediatric airway. Then for management of the difficult airway, she gave us several tools. We could use the LMA, the direct laryngoscope, the rigid bronchoscope, the fiber optic bronchoscope, and the tracheostomy. And of all this, she said, if we have a difficult airway, when we use a video laryngoscope as our first attempt, there's likelihood of having, it increases the success rate when we use a video laryngoscope. And she also mentioned that the fiber optic bronchoscope is the gold standard for management of difficult airway. By and large, thank you very, very much, Ma. We really appreciate every information that you've given us today. They're very, very interesting. So now the floor is open. Please, if we have questions, comments, please may we raise up our hands so that we take some of as much as we can take for now. Thank you.
I think there are some questions, interesting ones on the chat box before, if there is nobody speaking now, perhaps we can start with those ones.
Okay.
Thank you.
We have some comments. Great lecture. Thank you, Ma. Sorry, trying to get the questions. Okay, sorry.
I think one of the questions that I would like to address, is that okay, Dr. Abiola?
Yes, Ma. Go ahead, Ma. Go ahead.
All right. So one question was the use of LMA in the neonate. So we don't have a lot of experience or study with the LMA in the neonate, and I think the challenge is with the right size, right? Because again, they can be. We have the ones that are really, really small. So if you can find a small LMA, you know, the way that I think about an LMA, it's really a mask, but it's closer to where you want to deliver the oxygen to. So again, if it's sitting well, then it's pointing, like the holes are pointing towards the, you know, the vocal cords and the trachea, then it should work. And then an emergency situation, if you're able to place a small LMA in that situation and you're able to provide some ventilation, again, that's still sufficient. So the limitation in using it in a neonate population would be finding the right size to fit the neonate. Again, they can be, you know, very small, 2 kilogram or even less babies. And from what I've seen, I don't think that we have LMAs that are that small. So that would be the limitation. But again, if we did, I think it would still work because again, you know, the goal would really be just to deliver some, you know, oxygen and, you know, take out carbon dioxide in that situation. I hope that answers the question.
Thank you very much, Ma. We have another question also from Saeed. The question says, is there any difference in the use of iGel and classical LMA?
Yeah, so okay, so the iGel and the classical LMA, again, I feel like whatever is used depends on what is available to you. And again, all the different LMAs have different limitations. So I'll just quickly go back to the slide that kind of compares the LMAs. And I know with the iGel, the placement might be a little challenging, but one advantage is that one, it sits and it kind of almost feels like it expands, then you can have a better seal for it. And so the eye gel here, you can, see, I don't know, can you all see the slides here?
Yes.
Can you see the still slides? Okay, great. And so if you can look at the eye gel, right, you can use the eye gel to decompress the stomach. You can use it, with entry. You can use it. It's short enough that you can use it for the fiber optic, and then you can see like the maximal tube size that you can put in it. So again, it still facilitates being able to intubate through the eye gel. And again, I feel like with these different ones, based on your experience, some of them sit better than others, but it really depends on what you have available. I don't know if that answers your question.
Okay, thank you very much.
And I think one of the other questions is if we can, critically ill patients. I believe the question was use of LMA in a critically ill patient as well. Let me just find that. Right, so difficult intubation in critically ill patients. So I would say that I don't work in the intensive care unit, so I don't know how different that would be, but we do take care of critically ill patients in the operating room. Say we have a neonate that has necrotizing enterocolitis, so we'll still take care of them in the operating room. And again, it's really not different in terms of intubating them. Just have to be cognizant that in terms of like the dosages of medicines that we use for intubation. And we still are able to do mask ventilation in the kids if they're not already intubated. But again, being cognizant that you might not be able to use really high doses of sevoflurane or whatever anesthetic that you have, and they might be more susceptible to hemodynamic instability on induction. So being very careful about the dosing of medications. And then also, many times when the critical ill patients come to us, they already have a intravenous access, which again, I think is very, very important in this case. And so being able to, again, verify that you can mask ventilate the patient. And then, sometimes just because of the hemodynamic instability that can come with using our other intravenous drugs like the propofol or using sevoflurane, we'll actually just go ahead and paralyze the patients and then intubate, just to avoid the hemodynamic consequences of using large intubating doses of medicine. But again, I would specify that we don't paralyze the patient until we can establish that we can provide adequate mask ventilation, using, oral airway, if we can. So, again, that has to be important. We have to be important that we can mask ventilate before we go ahead and paralyze the patient.
All right, thank you very much, Ma. We also have another question from Dr. Chinedu Iwuha. It says, nasotracheal intubation in infants. How do you navigate the rapid desaturation associated with this group of patients vis-a-vis difficult mask ventilation?
Yeah, so this is where, again, like I talked about, it's really important to provide supplemental oxygen when you're managing, because you really want to take your time and optimize the position. And, again, if you're doing nasal intubation, again, you can still provide supplemental oxygen through the mouth, right? So you use your oral airway, can connect it to the circuit and still deliver some oxygen there while you're managing, right? Or if you're doing it the other way around, you can still, supplement oxygen through the nose. So again, and then also still maintaining spontaneous ventilation as much as you can, because again, one thing that can happen, especially, if you end up paralyzing the patient or you don't maintain spontaneous ventilation, then, when, things become really difficult, then you don't really have that exit plan. So you have to, so again, I would emphasize, being sure that you can mask ventilate the patient, and then finding a way to deliver supplemental oxygen in whatever form or combination, like the things that we've discussed before, will really help you and buy you more time so that they don't desaturate while you're securing the airway.
Okay, thank you very, very much, Ma. We have some other comments that are appreciating you for the insightful presentation. Thanking you for the great and enlightening presentation. I don't know if we have any other more questions that we have not taken. Okay, we have a comment. Thank you for the enlightening presentation, Dr. Peace. Thank you very much for the very thoughtful and informative presentation. So for now, I think that is how much. Okay, thank you very, very much, Ma. Well done. We appreciate the presentation and we also appreciate your very wonderful answers to the questions, Ma.
And I will just lastly mention, please feel free to reach out to me. I'm trying to get to the slide that has my contact information with any additional questions. And so that's my email address. So please feel free to reach out if you have any other questions or comments, or always looking for opportunities to collaborate on different initiatives. So thank you, everyone.
Thank you very much, Ma.
I think there's a hand raised up. Professor Elizabeth Owoli has her hand up.
Okay, Prof. Ma, you have the floor, Ma.
Okay, yeah, thank you so much. For the opportunity to have our colleagues, teachers, and it's been a very insightful teaching. Really, the rest, and this is good. I'm happy we have to give back. Sorry, I was logged out. I hope you heard me. I'm sorry I was logged out. My network is unstable. But just to say thank you so much, and hope that you can come back sometime to do as everybody participating.
Please, I have a comment. Hello, please, I have a comment.
Sorry, Ma, Dr. Elizabeth and Prof. Elizabeth is still on the floor, Ma. I don't know if
Okay.
No, finish speaking.
All right, Ma. All right, Prof. Thank you. Okay, please go ahead.
Speaking, I please let the Prof. I don't want.
All right, Ma. Prof. Ma, go ahead.
Okay, I want to congratulate Dr. Peace NF for that beautiful presentation. I love it. And even the slides, the way she took time to prepare it. Congratulations, my dear. Now, what I want to say is that sometimes we encounter patients with bone contracture of the anterior neck resulting from a gas explosion. It can be very, very challenging. I know many years ago, we had a case, and the only way we were able to intubate the patient was to pass a bougie and then reload the endotracheal tube over it. So I just said I should mention that in case anybody encounters, such a challenge, without other equipment, if other equipment are not available. Then I have the other, during your presentation, you did say that after passing LMA, and if somebody plans to pass a cough endotracheal tube through the LMA, it could be very challenging, especially in children because of the size, because the tube is curved. I want to suggest one can also pass a bougie, remove the LMA if time permits, and quickly pass an endotracheal tube, the cough endotracheal tube, over the bougie. Dr. Peace, are you hearing me?
Yes, ma. Yes, that is a great
Am
point.
I communicating?
You are communicating.
Then lastly, please, the question I want to ask. So the question I want to ask, in case of difficult intubation, you know, and when somebody has succeeded in passing the tube, what will you advise that at the end of the surgery, what time should that tube be, you know, what time should the patient be extubated, the trachea should be extubated, having encountered difficult intubation during induction of anesthesia? This one is very relevant because when some people do it very quickly and in a hurry, patient gets to the recovery room, gets to PACO, and the patient develops problem again. It becomes again very difficult to intubate. I want you to emphasize on that. Thank you very much. Congratulations once more, Dr. Peace Ene.
Thank you so much. Thank you so much, Ma, for highlighting those 3 points. Very, very important points that you have raised. So I completely agree with you about the bougie and the LMA. So that is one of the techniques that we can use to intubate. So again, even exchanging an endotracheal tube, you know, the bougie can be very, very helpful. So I completely agree with you. So if you have an LMA in place, you can put a bougie through that. And again, as you're passing it as one, you know, again, this similar technique to how we can just use bougie to intubate. So passing it through the LMA, again, the LMA just helps, you know, one, it helps us to continue to oxygenate and ventilate the patient while you're working. And then also NAMPRO works as a conduit, you know, for your, whether it's the endotracheal tube or the bougie or any stylet. And then so you can pass it on, and again, you know, with the bougie, the tip, you know, kind of against the trachea, to kind of, as it's going down the trachea, you know, you have that tactile feel, and then that kind of confirms to you that it's in there. And once you can, you know, positively confirm that the bougie is already in the trachea, then you can go ahead and take out the LMA and then now pass the breathing tube over it. So again, that's a great technique, and thank you for bringing that up. And so in terms of the extubation after difficult intubation, so again, thank you. I didn't really talk about that, but again, that's a very important point, important consideration. So one thing that I will mention is, you know, depending on how, you know, what the availability is, you know, I would advocate for any patient that's had multiple instrumentation of their airway to receive dexamethasone, like the airway dose, like the 0.5 milligram per kilogram, if it's available, to just help with the airway swelling. So they should get it early enough. At least that's what we do in our practice, so that towards the end, you know, you can help with the airway swelling. Because again, I can guarantee you that, you know, again, if you've had to, you know, go 2, 3, 4 times with the airway, that there will be some swelling. So that can help. And then towards the end, you know, again, that's where you should really decide, you know, it should be like a decision tree about, you know, should we go ahead and extubate this patient right now, or can we wait? So if they had work done in the airway, right, if they had like maybe an ENT procedure, you should really have a discussion about where, you know, should we keep this patient intubated, and if you have the capacity to extubate in the ICU under a more controlled setting, that, you know, that would be an important consideration. But I would say in any patient that has had the difficult intubation, and if there is a plan to extubate, the patient should be all the way awake. Like, so wake the patient up. They need to be following commands before you extubate them. And you can also do a cuff leak. So again, if you can ensure that the patient, that there's no significant airway swelling where you don't have it. So assuming you have a cupped endotracheal tube, right? You have to have like a positive cuff flick so that you know that again, the swelling is not too much that will be a difficult reintubation. And then the patient, like I said, should really be awake and be able to maintain their airway before you extubate them. So I would say that would be my recommendation.
Thank you very much, Dr. Peace. We really appreciate you. At this point, I want to recognize the presence of our very distinguished senior colleagues, teachers, and mentors who have taken out time to be here at this webinar with us. I would recognize the presence of our Professor Elegbe, Professor Edonwoyi, Professor Desalu of the Paeditric Anesthesia Society of Nigeria, Dr. Adesina, the Society for Specialists in Airway Management, and our immediate past president, who has already spoken to us, Professor Elizabeth Ogoluwanso. We really want to appreciate your presence here with us today. Also want to recognize and appreciate the presence of Dr. Ansbert Sweetbird from Dar es Salaam. We really appreciate everyone's presence. So right now, welcome comments from our teachers, Professor Elegbe, Ma, Professor Desaluma, and Dr. Adesina. Please, the floor is open, Ma, for you to address us, and let's hear your comments. Thank you very much.
Hello, good evening all. Can you hear me, please?
Yes, ma'am, we hear you, Prof.
This is
Yes, ma'am, we can hear you, ma'am.
Yeah, this is Desalu. Thank you very much, Dr. Ene, for the great talk. You mentioned earlier that you couldn't get data on difficult intubation. The Ghana Medical Journal, I think 2010, we have a paper there on difficult intubation. We had quite a high incidence of 2%. But that was with cleft patients, which is not unexpected. So I can send you the link so you can add it to the next time you're giving your lecture. So you can have some reference from Nigeria. You also asked about the syndromes that we usually see. And we do see, because I do quite a bit of clefts, we do see Pierre Robin, and we'll see golden horse syndrome, which I noticed wasn't there. Maybe you don't get to see them where you are. And they can be quite difficult intubations as well. Yes, I am also an advocate of giving steroids if I've had multiple attempts at intubation in children. And it helps a lot, I think so. And it works very well when you choose to extubate the patients. Besides those points, I just want to say thank you very much for your talk. Thank you.
Thank you very much, Prof. Professor Elegbe, Ma.
Can you hear me?
Yes, ma'am.
Yes, ma'am.
Hear you, Prof, ma.
Yeah, good evening, everybody.
Good evening, ma'am.
Congratulations to the speaker. I think it's a very informative and well-covered lecture. I think the emphasis is on oxygenation. Hypoxia in children should be avoided as much as possible. Every effort must be made, and multiple attempts should also be avoided. When in doubt, you stop, oxygenate, and call for help. You must also realize that the airway is very delicate. And the moment you inflame the airway, the resistance to spontaneous ventilation of the child becomes very difficult after you finish the manipulations. So, like Poiseuille's law, you know that 1 unit of reduction in the diameter will give you 16 times resistance. So you must always keep that in mind. And I must congratulate her. I think she's really covered most of the ground in difficult airway in the pediatrics. Thank you so much.
Thank you very much, Prof. Dr. Adesina, you have the floor, ma.
Thank you very much, Dr. Adejumo. Can you hear me?
Yes, ma, we hear you very well.
Yes, thank you very much, Dr. Ene, and thank you very much for all our senior colleagues that have made comments concerning this lecture. Dr. Ene, congratulations. I just want to emphasize a few things that Dr. Ene mentioned, and that is assessment. Our assessment of these patients should be both anatomical and physiological. One of the questions was, what are the guidelines in the critically ill child? So it's important that you don't just assess your patient anatomically, but also physiologically, so that you can do adequate resuscitation before you attempt securing or managing their airway. The second thing I want to emphasize is training and retraining. It's not good enough to say we have a fiber optic sorry about that. It's important that we ensure that we know how to use the equipment available to us. And while we move towards getting better equipment, we develop protocols and practice with what we have at our institutions. So if you have a fiber optic, it's useless to you if you've not learned how to use it. So we need to encourage our residents to train and retrain themselves regularly on all this equipment, and particularly when they don't have difficult airway, so that when they get the difficult airways, then they have already experienced in using this equipment. Then lastly, I'd like to say there's a DAS guideline for extubation after a difficult airway. And when we look, if you can check online for it, it has various things that you should consider and the questions you should ask yourself before you attempt extubating after a difficult airway. So there's a mnemonic, 4 Ps. So please, you can check that out after this presentation. Thank you very much, Dr. Ene. Thank you, NSA.
Thank you very much. Thank you so much to all our teachers, mentors, our trainers. We appreciate every input that you have made to this presentation. At this point, may I invite the NSA President, Dr. Usola Briggs, to take over from this point. Thank you very much, ma'am.
Yes, thank you very much, Dr. Adejumo, for this moderation, beautiful one you have done. And I also want to thank the speaker wonderfully. I want to plead with you, please don't begin to disappear, because I've noticed that once I start talking, the audience becomes less than 100. Please don't disappear, because I want to appreciate you all. So I want to just give us a brief genesis of how this today's meeting came to be. Back there in Singapore, we met, the Nigerian team met Dr. Ene at the WFSA stand, and we found what I can describe as somebody whose heart was panting for Nigeria, for NSA. And immediately we clicked, and then she was willing to do something and make impact. And here we are today. So Dr. Ene, thank you so much. Let me quickly tell you, Dr. Ene, you rightly belong to the Paediatric Anesthesia Society of Nigeria, PASON. You're actually NSA, but I want to tell you that there's a society called PASON. Professor Desalu is the president. So you rightly belong to that group as a pediatric anesthetist. You also belong to the SAM. We have a society also called SSAN. That is the Specialist Society in Airway Management, Society of Specialists in Airway Management. So, and the presidents are here represented. So you can see what you have done, Dr. Ene. You have brought some societies together today. And of course, our big mama, our great grandmother of anesthesia, Professor Legbe, mark my word, great grandmother, she's also here. Of course, my immediate past president. So thank you to every one of you. And I think we shall work on the modalities later. If you don't mind, Dr. Ene, you need to join the two societies I've mentioned, including NSA. So to everyone here present, I must say thank you so much. To my chair, Dr. Deity, thank you for your sleepless nights I know you undertake to get this mission accomplished. And on that note, I'm happy. I'm looking at the numbers. You have all not disappeared. So thank you for that, everyone. So on that note, let me just call on the PRO to come and give us a roundup of the events that are upcoming. Please get yourself involved in this. Somebody was asking, how does WFSA help in getting LMAs? Let me tell you that WFSA has been supporting directly and indirectly. We have the society, Dr. Adeshio, what's the Airway Incorporated, that has been sharing Airway devices for the past 4 or 5 years now. Also, we have our Professor Olomu, who comes to Nigeria and also shares LMA. So LMA for pediatric age. Of course, the SAM society, the SAM, during its conference, so there's a conference upcoming now, my dear doctor, asking for how pediatric LMAs can be obtained. So please do yourself well to be available at SAM conference. That's the immediate one present. I'm sure you're going to get a pediatric LMA at hand. In the last NSA conference, we had a lot of devices that were donated by Professor Olomu, and we shared them amongst all those who were present for them to take down to their centers. So I hope I've answered your question. On that note, Dr. Shelley, please, you have the floor. Briefly, thank you. I don't want you to disappear, so make it brief. And then our chairman should tell us what is next. Thank you.
Thank you, ma'am. Good evening, all our mentors and trainers. And good evening, Madam President. Thank you, our presenter. The highlight of our upcoming event as follows. Our NSA OGM will be coming up either in July or August. The definitive date will be announced soon. And the All African Anesthesia Congress will be taking place in South Africa in September 13th to 19th of September 2024. While our annual general meeting, that is the Nigerian Society of Anesthetists annual general meeting and scientific conference, will be coming up in November at Enugu, the coast city state. And the theme of that conference is workforce well-being. We also want to use this opportunity to enjoy all our members to please pay up their dues so as to move the society forward. Thank you, and God bless you all.
Okay, thank you very much, Dr. Shelley. Chairman, Education Committee, over to you. What do we have next and when? Dr. Deity, are you still there?
Yeah, I'm around.
All right.
Can you hear me?
Okay. Yes, we can hear you.
Yeah. So our next webinar will be next month. We're working about 3 different topics. We don't know, one of which we have missed out last year on ethics in anesthesia practice. So about that, we will announce it before the time. But having said that, I want to inform Dr. Peace Ene that you have joined us. Professor Lebe has been waiting for this moment. She said I should remind her. And then Professor Domoyo never missed out this webinar. And you can see that the president person, Professor Desalu, I'm sure they won't let you go. So you are with us. Then I want to say that what the President Sam addition didn't tell you that in the last 2 years, they have done so well in trying to get all these devices in all our teaching hospitals, including secondary level care. And that's why you won't be surprised in the questions you asked in the presentation. You see that they are having 4, 5 out of the 7 you listed. Okay, so we have we are really doing well in that regard. So we ask you to remain with us. We will come for you very shortly, but we will discuss. I'm sure there are areas that we can really do more in this regard, either through person or a son. So thank you very much, and we really appreciate. God will bless you abundantly. I want to say thank you to everybody here present, and we'll see you next month.
Okay.
Thank you.
Thank you very much, my Chair Education Committee. Professor Dr. Ene, now you can see my face. We saw last in Singapore, so thank you so very much once again. And
Thank you.
have a lovely Mama, I don't worry. Thank you very much to you, Ma, for being present and taking time to support us. And our colleague from Tanzania, I can't remember your name. Thank you so much. It's nice having you here. And to everyone here present, I can see Dr. Lawal. Thank you to you. The Secretary of Person was here earlier, Dr. Oluwarotimi. I'm not sure he's still here to mention all your names, but you have all done well. The count was about 198 at the time when I picked on the participants list last. So it's been a very good outing this evening. And despite all the busy business